I would like also to thank the SSBMT and EBMT for giving the opportunity to talk about hemoglobinopathies. And I wish I'd be there, but I hope it would be possible in the future. So I selected, in fact, 3 main abstracts in transplantation in patients with hemoglobinopathies. So these are my disclosures. So first, I selected the abstract of Anderson Rocha that has been presented on behalf of EuroCord and the Pediatric Disease Working Party. We know what was about HLA, identical related cord blood transplantation in patients with thalassemia major or sickle cell disease. And it was about the role of chimerism on outcomes. We know that transplant is the only currently available curative treatment for patients with transfusion-dependent thalassemia and sickle cell disease. And the interest of families affected by hemoglobinopathies on related transplant, including cord blood transplantation, has increased, especially with the advances in vitro fertilization and the possibility of embryo selection of an HLA identical disease-free donor. To increase the knowledge on related transplant for hemoglobinopathies, they performed a retrospective analysis of HLA identical related cord blood transplantations for thalassemia and sickle cell disease from the EuroCord and EBMT registry. We know that it has been described that patients that achieved stable mixed chimeria are transfusion independent. However, data on risk factors for mixed chimeria are still scarce in the literature. So first, they reported 230 patients who were transplanted for thalassemia. The median follow-up was 72 months, so almost 6 years, and the median age at transplant was 6.8 years, 4 years. You see that half of the patients received a single cord blood, and half received cord blood plus bone marrow as a graft source. Most of the patients received a myeloablative conditioning regimen, and half of the patients received ATG for engraftment and GVHD prophylaxis. In all, 90% of the patients achieved neutrophil engraftment, and at day 100, for the chimerism, 60% had a full donor chimerism, 23% a mixed donor chimerism, and 9% autologous reconstitution. 16 patients required a new transplant after the first cord blood transplantation. 27 patients developed acute GVHD and 13 chronic GVHD. 7 patients were dead at the last follow-up, and the main cause was infection. What about chimerism? So they had the data for 121 patients. 72 patients had a full donor chimerism at day 100 and also at the last chimerism. 19 had a mixed donor at day 100 and at least chimerism, and 10 had a mixed donor at 100 at day 100 and a full donor at the last chimerism. What about GVHD? So you can see that there are not so much patients, but you can see that 14% developed acute GVHD grade 2 to 4 with a full donor chimerism, and 10% in a mixed chimerism. So the mixed chimerism didn't really protect to develop GVHD. And in the chronic GVHD, 9 patients developed chronic GVHD and 2 with mixed chimerism. So what about sickle cell disease? So they reported the data for more than 100 patients with median follow-up of 5 years. Median age of patients who were transplanted with the cord blood were 7 years. And 68% received a single cord blood and 32% cord blood plus bone marrow. Most of the patients received, as expected, a myeloablative conditioning regimen, and almost 90% received ATG for engraftment and GVHD prophylaxis. So almost 96% of the patient achieved neutrophil engraftment. And when they look at the chimerism at day 100, 64% have a full chimerism, 34% a mixed chimerism, and 3% autologous reconstitution. Only 2 patients in this series required a new transplant. 11 patients developed acute GVHD, and one children developed chronic GVHD. 2 are dead at the last follow-up, and 1 dead of disease complication, and the other of infection. When they look at the chimerism trend, we can see that 40 patients had a full donor chimerism at day 100 and at the last chimerism. And when you look at the mixed donor chimerism at day 100, 19 had also least donor at the least mixed chimerism at the least chimerism. What about survival? So at 1 year, so there are excellent results, I think. At overall survival was at 1 year 99%, and at 5 years 98%. And when they look at GRFS, at 1 year was 19%, and at 5 years was 87%. When they look at chimerism and GVHD, almost 8% of the patients with mixed chimerism develop acute grade 2 to 4 GVHD, but it's only 2 patients. And for chronic GVHD, only 1 patient developed mixed chronic GVHD with a mixed chimerism. So for this abstract, the conclusion that was survival after HLA identical cord blood transplant for transfusion thalassemia patient and sickle cell disease is very encouraging. The primary result, mixed chimerism at day 100 were 23% and 34% in thalassemia and sickle cell disease respectively, and most remained mixed chimerism at the last follow-up. But they had a similar survival, and this is the main point for this patient. Just 1 patient, thalassemia and non sickle cell group with mixed chimerism progressed to autologous reconstitution. And to understand why patients develop mixed chimerism, a risk factor analysis is needed. So for the second abstract, it was presented by Bernardin and colleagues from the French Society of Stem Cell Transplantation. In fact, they look at a patient with sickle cell anemia and hypersplenism. In patients with sickle cell anemia, the presence of Howell Jolly bodies is associated with splenic dysfunction. And we know that splenic dysfunction appears progressively during aging and after splenectomy. Previously, improvement of splenic function has been found in several sickle cell disease patients after transplant. So the goal of this study was to evaluate splenic function from birth to adulthood at annual checkup, to evaluate the impact of transplant, and to compare the impacts of splenectomy, that could be partial or total, when patients were transplanted or not. The first, we'll look at Howell Jolly bodies that were analyzed by Bengunva Jimza stem blot smears, and they did a score. A score for Howell Jolly bodies were assessed and prospectively recorded at each annual checkup. And you can see the grade was 0 when they were absent, grade 1 when it was less than 0.2%, grade 2 when it was less than 0.5%, and grade 3 when it was more than 0.5%. In total, more than 4,000 annual checkups were available. So first, they saw that Howell Jolly bodies mean scores were increased with aging in sickle cell disease patients. It was a little bit expected. And it was visibly lower in sickle cell SB+ than in sickle cell anemia patients at each assessment age. Secondly, they did a multivariate they performed multivariate analysis to look at risk factors, and they defined that the genotype, splenectomy history, and age at checkup were all strong, significant, and independent risk factors for Howell-Jolly bodies score more than 1. Then they look at the score according to the spleen status in non-transplant children. Among almost 750 anemia sickle cell disease children, 86 have been splenectomized at the mean age at 6 years, and the mean score was significantly higher at checkup in splenectomized than in non-splenectomized children. However, the difference between both populations decreased with aging because of the progressive splenic dysfunction in non-splenectomized patients. What about the score post-transplant? So 5 patients had a total splenectomy before transplant, and 8 had a partial splenectomy before transplant. Before hematopoietic stem cell transplantation, mean Howell-Jolly body were similar in the 3 groups. So you can see on the right, the patients were not splenectomized, we had a partial splenectomized and a total splenectomy. But after transplant, the mean Howell-Jolly score was lower in non-splenectomized, as you can see there. It was null in those with partial splenectomized, but it was stable in patients who had a total splenectomy. And so this study confirmed further that splenic dysfunction increased with aging in children with sickle cell anemia. Transplant improved splenic function in non-splenectomized and in partially splenectomized children, and improvement was correlated to young age at transplant. So in children with indication of splenectomy for recurrent acute splenectomy sequestration or hypersplenism, and who have an available HLA identical donor, the present study suggests that partial splenectomy may be useful to preserve splenic function, and providing to be performed very close to transplantation to avoid hypersplenism recurrence before transplant. And then the third abstract was about a patient who did not have a HLA matched sibling donor, about sickle cell disease patient. So we know the indication for transplantation in patients with sickle cell disease. And when they look at the registry, you can see that around 8% of the patient doesn't have a match-related donor. Gluckman and colleagues have published they compared, in fact, alternative donor hematopoietic stem cell transplantation for sickle cell disease in Europe. And you can see that 49% received unrelated donor, 4% unrelated cord blood, and 47% haploidentical donor. And the graft donor was 16%, and when they look at the 3 years of overall survival, it was 86%, and 3 years event-free survival was 72%. And there were no difference between match unrelated donor and haplo donor. Like 10 years ago, the Hopkins group approach published a new conditioning regimen for patients who had a sickle cell disease and who have haplo donor. And in fact, the conditioning regimen associated ATD, fludarabine, cyclophosphamide, and TBI. And they reported 14 patients. The TRM was 0, and no patient had developed GVHD, but you can see that 50% developed graft failure. However, the Hopkins modified approach to improve engraftment because they passed data, we had a lot of acute GVHD. So Dida and colleagues have reported the preliminary results of the study that is called DREAD-APLO. So this is for patients between 7 years old and 40 years old. The conditioning associate fludarabine, tau-theta, cyclophosphamide, ATG, and 2-grade TBI. And the stem cell source is bone marrow. So they have already included 19 patients with a median age of 17 years old, and the median follow-up is 1 year and a half. Graft failure is 5%, so it's quite acceptable. One patient died. 47% developed grade 2 to 4 GVHD, and 22 moderate of severe GVHD. And at the last follow-up, 11% developed chronic GVHD. When they look at the primary results, they're quite interesting and good, because the overall survival was at 1 year 93%, and the 1 year EFS was 87%. However, we need a longer follow-up to really conclude about this study. So there is a recommendation for sampling, HLA typing with symptomatic sickle cell disease. Match-related transplant in adolescents and adults. There are encouraging data with the non-myeloablative NIH approach, but we need a longer follow-up to confirm stable mixed chimerism, cure of sickle cell disease, and also to know about fertility. Haploidentical transplantation is an acceptable alternative in case of severe sickle cell disease, and in this case, could move with improvement of transplant and standard of care. And you're aware that it's very important to involve patients in transplant decision. So I would like to thank all my team and my mentor, Professor Moti, and I would like to thank you for your attention. I will be pleased to answer any questions. Thank you.